All right, let's talk about some of the prescription drugs, all right, because they come in various flavors. There's antidepressants, there's the benzos, there's something called the Z drugs, which is zolpidem and esopiclone. Zolpiclone. I don't never prescribe it, I can't pronounce it, I'm glad you're here. We've got melatonin receptor agonists, and we've got the orexin antagonists, right? Let's go through them one at a time. How do they work? What's going on with them?
Well, certainly they're the prescription drugs that are not indicated for insomnia, right? Which many physicians use. The sedating antidepressants, trazodone is a favorite, low-dose mirtazapine is another one, and so on. So why do we use them? Well, we think that they're safer. Maybe we think they're not addictive, so we like to use them. But also there's a perception sometimes that if you add them in low doses, maybe you'll also treat patients in a panacea way. You're treating an underlying depression or an anxiety disorder, although there are no data to show that that's true, but we sort of believe that and sometimes use them. These drugs tend to work sometimes in some patients, but generally there are no good studies showing that they do work predictably well. And to Nicole's point, they may cause daytime sedation and other problems during the course of the day. So these are the prescription drugs not indicated for insomnia we tend to use for insomnia.
But one of the reasons why I think that happened is because for many, many years, physicians thought that the best drug to use, whether it was zolpidem or similar types of, you mentioned the Z drugs,
right,
and the insurance companies made it too difficult to prescribe those.
Why is that? They were expensive?
They were expensive. And right, I think that drives insurance companies. but
It's kind of a Cheshire cat view over here.
So, and these other medications that Carl just mentioned were cheaper. And much more available, and nobody put any restrictions on them. You didn't have to get any prior authorizations. You could give them a full month's supply, and nobody bothered you. And it is a problem that sometimes they create too much sedation, and people have a hangover effect and so forth.
All right, so why don't we run these down a little bit? Take them one at a time. The antidepressants.
So just kind of build on the antidepressants. So, there's an older antidepressant too, doxepin, and I think a unique medication because you're using it at lower doses. So to get back to the point that was brought up, oftentimes we're using lower doses and not really depression or anxiety doses, but we're using it for oftentimes the histamine blockade to help with that sedation and maybe that quick improvement in terms of the sleep quality. But over time, we may lose that benefit. And what I too often see and would love to hear the panel's response is the dose getting escalated, and where we started it originally for sleep, we now might be bumping up the dose and we're not really addressing the sleep as well again, and that medication persists. So I think it's something is why do we start it? Do we really evaluate it? Because if we're using that antihistamine effect at the beginning, the higher doses of mirtazapine, for instance, they don't have that antihistamine effect as much. So I think pharmacologically there's some unique properties. And the same with doxepin. When we push up the doses of doxepin, you increase the anticholinergic effects, which we want to avoid in older adults. So I think it's really important when we think about the pharmacology, we think about the dose-related effects. And when we look at these medications, and we'll talk about it, maybe lower doses might be safer, but depending what we're treating, they may not always be beneficial.
Well, a good point. And as you know, low-dose doxepin 3 and 6 milligrams is indicated for insomnia. It's a pure antihistamine. Whereas when one bumps up that dose to 50, 150, becomes an antidepressant with significant anticholinergic and other effects.
But you hinted at something that I personally think is overlooked all the time, is that they're using these sedating antidepressants, which are not great antidepressants, and they're going to sort of backdoor it to treat the anxiety and depression, and not enough attention is paid to the anxiety and depression in these patients.
What about benzos? The number of folks that come in to see me preoperatively, or I find out in the ICU, dad's on Valium, Ativan, for sleep or something else, and it's on all the time. It seems to me that there's a lot of folks out there on benzos. Do they work? Are they safe? Are they useful? Who wants to jump in on this one?
Well, clearly they work. Otherwise, they would not be indicated for insomnia. That there are a number of drugs which are benzodiazepine receptor agonists or GABA receptor. They promote GABA receptor activity, which in fact are indicated for insomnia. These are the longer-acting drugs, the Dalmains and so on of old.
Boy, there's a name I haven't heard in a long time.
Flurazepam, the first benzodiazepine hypnotic,
Sure.
Like in 1970.
70 by Hoffman LaRoche,
1970?
1970, yeah.
How old do you feel right now?
going all the way up to
Right.
triazolam or halcyon, which we don't use much anymore, even though it's a shorter acting benzodiazepine, because of the potential for daytime sedation, amnesia. As you know, it was used in higher doses than it should have been used in, producing amnestic disturbances. The fact is they do work for sleep. The problem is they have baggage associated with daytime sedation. Also, in the case of some of these, they do also lead to tolerance and lack of activity after continued usage. So we've seen a movement away from these drugs towards the sort of what we consider to be, or maybe not entirely accurate in every case, but at least we think the Z drugs, which tend to be maybe safer or less problematic.
Again, some of those drugs that are tough to pronounce. We'll call them the Z
Right,
drugs.
the Z drugs.